Good morning. Thank you for being here today. I hope you all are having a good conference. Welcome to Leading the Pack Nutrition Research. My name is Tara Griffin. I am a registered dietitian at the University of Minnesota. My co-chair is Alex Wilson, clinical research manager at National Jewish Health. We have no disclosures related to this session. Our learning objectives today are as follows. Review the impact of CFTR modulators and PPI medications on clinical outcomes, including GI symptoms, pancreatic function, intestinal inflammation, lipid profiles, and fat absorption. Describe the impact of large nutrition studies on future clinical trial design and clinical care guidance, and discuss how clinical dietitians can partner with clinical research teams. In today's presentations, you'll be hearing reports from the PROMISE, BEGIN, and GOAL trials. Also a presentation of a recent pilot study looking at PPIs and fat absorption. And finishing our session today, we will hear from Dr. Jessica Alvarez about elevating the role of dietitians in clinical research. The work of all of our speakers emphasizes the importance of nutrition research within the evolving CF care paradigm. In keeping with the title of our session, this work is leading the pack, or leading the way, if you will, to establish the CF nutrition care models of the future. And with that, I will introduce our first speaker. Dr. Sarah Jane Schwarzenberg is a professor of pediatrics and the chief of the Division of Pediatric Gastroenterology and Nutrition at the University of Minnesota. She is also the medical director of the Women's and Children's Service Line and vice chair for clinical affairs of the Department of Pediatrics. Her clinical and research expertise focuses on CF-related gastrointestinal and nutritional complications, and she is the co-chair of the CFF Digest program with Dr. Steve Friedman. Please welcome Dr. Schwarzenberg.
I want to thank the moderators for inviting me to speak here, and I'm really thrilled by this huge number of people who are here on a Saturday at the end of the meeting. So I'm going to tell you a little bit about the outcomes at 30 to 42 months of the PROMISE GI study, which is being done in children and adults with cystic fibrosis who are more than 12 years of age. I have one disclosure, and that is that I'm a consultant for UpToDate. We all know that gastrointestinal disturbances in CF are a source of tremendous abdominal pain, diminished quality of life, and poor growth. Patients experience abnormal digestion, malabsorption, abnormal intestinal secretions, dysmotility, acidic intestinal pH, and intestinal inflammation. We wanted to look at the effect that the neuromodulator, ETI, I suppose it's not that new anymore, had on gastrointestinal symptom frequency, severity of intestinal inflammation, and exocrine pancreatic function. The PROMISE study is an observational prospective cohort study at 56 U.S. centers in the TDN. The inclusion criteria were age 12 years and older, diagnosed with CF, and at least one F508del allele. Patients had to be stable on their clinical care before enrollment. Abdominal symptoms in this study were measured by the PAC-SIM, the patient assessment of constipation symptoms, PAGI-SIM, the patient assessment of upper gastrointestinal symptoms, and PAC-QOL, the patient self-administered questionnaire to assess quality of life related to lower gastrointestinal disorders. We looked at these at baseline, 1, 3, 6, 18, 30, and 42 months. So these are patient-reported outcomes. We also looked at fecal calprotectin and fecal elastase 1. All patients served as their own controls, and we're going to show the results for baseline and for the questionnaires up to 42-month time points, and for the stool studies up to 30-month time points. I want to emphasize that this data is preliminary. There's a lot more data analysis and a little more data collection going on, but I think these results are pretty reasonable. So we'll look at the demographics and how many people completed the PROMs. As you can see, the mean age was 25 years, and about 50% of the participants were naive to modulators. We had the privilege of starting this during the pandemic, and so while our baseline completion of our proms was about 80% or so, now out at 42 months, we're in the 57%, 58% range. Perhaps not as good as we'd hoped we would be, but not bad. So I'm going to talk about the PAGI-SIM first, and the structure of the report of the PAGI-SIM data will be similar to the report of the other PROMS data. The PAGI-SIM is scored between 0 and 5. You get a total score and you have 6 domains. On this slide, the total score and the domains are on the left. And at the top, you can see that we're looking at data from 1 month, 3 months, 6 months, 18 months, 30 months, and 42 months. The red line that runs down the center of each of those blocks is the baseline. So all of the data is being shown to you relative to the baseline. Numbers to the left of the baseline are improvement. Numbers to the right of the baseline are worsening. It's, I think, pretty easy to see that in most of the months and most of the domains, there is a slight improvement in each of these domains. However, the improvement is extremely slight. As I said, this is a PROM that is graded between 0 and 6, and the highest level of change that we have is 0.25. So these are very small changes. The PAC-SIM is graded between 0 and 4 with 3 domains. This is similarly structured in terms of the results being compared to baseline. And again, the results are extremely minimal changes, most of them less than 0.25. The PAC-QOL is graded between 0 and 4 with 4 domains. And similarly, we have very small changes in the quality of life related to constipation. We also turned to the minimal clinically important difference that has been calculated for these 3 PROMs. You all may be aware of the recent article by the Galaxy group looking at the Galaxy data and using that data to quantitate a minimal clinically important difference for these 3 PROMs. MCID, as opposed to statistical significance, establishes how meaningful a change is to someone's life. And this may be calculated either through a distribution method or an anchor-based method. For the 3 PROMs I have shown used in this study, MCID was calculated for each domain using data from the Galaxy study and the distribution method. This group also did some anchor work using data from PROMIS, but I'm sticking with the distribution data here. Comparing the changes in our data with the reported MCIDs demonstrated no clinically important improvement in our PROMs over 42 months. So now let's turn to our fecal biomarkers. Fecal calprotectin is a measurement of inflammation. We usually assume that the fecal calprotectin comes largely from the intestine. However, I think we know that there is some calprotectin in swallowed sputum, and so it's not always a perfectly clean estimate of intestinal inflammation. In this graph, the left-hand axis, the y-axis, is the level of fecal calprotectin measured in micrograms per gram of stool. And the x-axis is the baseline 1 month, 6 months, and 30 months data. Fecal calprotectin drops significantly immediately after the initiation of ETI in our patient population and remains normal at least up until 30 months. So it's a well-sustained change. Fecal elastase is a surrogate of pancreatic function and is often used to determine if individuals are pancreatic insufficient, with some caveats. On the left-hand side is, on the y-axis, is the measurement of fecal elastase in micrograms per gram of stool. And again, on the x-axis is the baseline 1 month, 6 months, and 30 months results. All but 2 of our participants were pancreatic insufficient, maybe 2.5, at the baseline measurement. We have 1 who's pancreatic insufficient at the 30-month study. You have to remember we did lose subjects as we went along, so our N is 131 at baseline and 87 at 30 months. One of those pancreatic sufficient people may have decided to drop out. But the important thing is that the mean level of fecal elastase has not changed during this period of time. So I think it's pretty clear that our older participants, people who are 12 years of age and older, are not seeing an improvement in their pancreatic function. So in conclusion, while you can see some trends towards improvement in gastrointestinal symptoms with ETI, the changes in older children and adults are minimal over 42 months. Now, I am an eternal optimist, and I believe that somebody who's lived 25 years with partial obstruction in their gut and thick inspissated mucus might not be able to turn that around in 42 months. Maybe it's going to take 5 years or 10 years to really make a huge difference in the intestinal function. So I don't think we should, I think we can keep giving ETI. That's what I'm saying. Fecal calprotectin improves quickly after the initiation of ETI and remains in the normal range for about 30 months. And pancreatic insufficiency is unchanged in older children and adults after 42 months of ETI. I want to thank all the people with CF and their families who participated in Promise GI, all the centers that collected data, and the Promise GI team. Thank you.
Thank you. Well, we will open it up for questions now after each speaker. So if anybody has any questions, please pop up to the microphone. Well, I have a question for you. As a dietitian that moved into the clinical research space, what are some things that dietitians could do or did do to help with recruitment for Promise, and then also helping with retention of those participants in Promise?
I think that dietitians are probably key members of the CF team, and they have more contact often with the patients than the pediatric gastroenterologist. I think I can't give you specific examples or data, but I can say I think that dietitians have been very important in encouraging people to look at this, at the effect of ETI scientifically. And I think that's really important.
Thank you.
Hi, Jill Sullivan from the University of Vermont. Thank you very much for the presentation. It was really amazing to hear all these outcomes. I was wondering, anecdotally, it seems like I've been able to pull a lot of patients off of laxatives as they're starting ETI.
Yeah.
Is that information that was collected as part of Promise? And
it has
thank
been.
you.
So we've collected the Bristol stool study and a few other questions about constipation and diarrhea, and we have not found a statistical change I don't think that means that what you're experiencing isn't real. It's just not showing up in the data the same way. And maybe we need to be looking at it in some way differently.
Thank you.
Hello.
Hi, Sarah Jane. Katie Larsnody from University of Iowa. So I was talking to our fantastic research team, and they just offhandedly admitted that one of our adult patients hates prose and just fills out whatever.
Don't tell me this.
And
I don't want to know this.
so what I actually want to ask you is, that was really scary to me. I'm eternally optimistic and assume all of our patients are enthusiastically doing everything we ask them to do in our research studies. But I was wondering if you think that people who have more GI symptoms and persistent GI symptoms would be more likely to continue to fill out the prose.
I don't know for sure. We have analyzed some of this data using, at least in the beginning, using our, looking at patients who have more symptoms and not found any more difference. And these, as you know, these particular pros were selected with the CF community. We asked the CF, we gave them 2 or 3 different ones and asked them to select the one they liked the best. But I'm learning more than I really wanted to know.
All right, we have a question for you. Would you recommend the PAGI-SIM, PAC-SIM, or PAC-QOL for in-clinic use?
I would not. These are very long questionnaires. And I think there are some shorter questionnaires. I think about Dr. Quittner's QOL questionnaire. There are other questionnaires that I think are much shorter that you could use for patients in the clinic. I think your patients would rebel.
Right. Yeah.
Do you think that diet quality, perhaps a lack of diet change in dietary intake, may play a role in the lack of change in constipation and GI symptoms in the PROs?
Yeah, I don't know. I think that's a really good question. The alteration in diet quality is something that I think is really an exciting opportunity for people with cystic fibrosis. I think for many years we've fed them a diet that, for every good reason available, we have fed them a diet that is really high in, what you would call bad fats. And we have an opportunity to help them make some really healthy changes now. It would be a good idea to maybe do a little before and after analysis of that to see whether that's making a difference in how they feel. It's going to make a difference in their tissues.
Thank you so much.
Thank you.
Thank you.
And thank you.
Great. Our next speaker is Dr. Scott Donaldson. He is an adult pulmonologist who has focused his career on cystic fibrosis. He's the Associate Director of the UNC Adult CF Center, co-PI of the UNC Therapeutic Development Center for CF Clinical Research, and is chair of the Translational Advisory Group that represents TDN sites and advises the CFFT. His research focus has been on the measurement of mucociliary clearance, or MCC, as an outcome measure for new therapies that target defective MCC in CF.
Thank you very much for the invitation, for organizing this great session. Very impressed by the size of the turnout on Saturday. It's a long, somewhat exhausting conference for sure. And oh, by the way, the picture that you're seeing there is not me pre-conference. This is Dr. Alex Despotis, who's a 5th-year combined adult pediatric pulmonary fellow at UNC, and this is really her work. She's responsible for everything you're going to see, but unfortunately she couldn't be here to present it today. So these are my disclosures. We first want to thank the CF Foundation for a grant to Dr. Despotis for the work I'll present today, and my other financial disclosures, which I think are irrelevant. So for background, so I started taking care of patients with CF in the early 90s, and I distinctly remember hearing from my clinical mentors that, the one break that people with CF got was they weren't going to develop heart disease, part because they didn't live long enough, in part because their cholesterol levels and lipid levels were so extremely low. So that was the one thing we didn't have to worry about. So you can imagine our surprise when in recent years we actually had 2 women with CF in their 30s develop ST elevation myocardial infarctions at our institution. And then certainly in the literature and at this meeting, we've seen several other case reports of similar instances. So this is clearly evidence that something is changing. I'll go through a bit of data suggesting that the very low lipid levels that we've traditionally seen is changing. And so I think overall, I think there's a lot of evidence that times are changing in CF in this regard as well. So what do we know about cardiovascular disease in this era of highly effective modulators? Well, clearly, this is a population that's aging, getting older, thanks to modulators. As people get older with CF, we expect more and more people to have CF-related diabetes, another risk factor for cardiovascular disease. The population is gaining weight and actually seeing rates of obesity similar to the general population. And we're seeing more and more hypertension. So lots of risk factors that are accumulating in this population. So this is some pre-modulator data relevant to lipids. And you can see that as I was taught, that people with CF before modulators pretty much always had very low levels of cholesterol and LDL. And so given the cases of myocardial infarction that we had, we wanted to really look into this question. And this was really our kind of first attempt, our first foray into seeing if in the presence of modulators, lipids might be changing. So in this single institution retrospective look, we used our data warehouse to identify patients with CF who were started on a highly effective modulator and who had had lipid levels checked within 5 years of starting modulator and at any time thereafter. We eliminated patients who had had a transplant, which may have independent effects on lipids, and we eliminated patients with type 1 diabetes. And so these were the characteristics of the 41 patients who are left. You can see it's not a typical CF population, perhaps, so it was very female predominant, with 2/3 being female. The average age at the time of starting modulator was 40 years, so pretty old. Baseline BMI was 25, so certainly higher than the average BMI in the registry. 56% of the patients in this sampling had CFRD and 22% had hypertension, so a fairly unique population. At the time that the post-modulator lipid panel was collected, patients had been on therapy for an average of 18 months. So this is what we saw in this retrospective look. So indeed, what we observed that total cholesterol and LDL cholesterol increased over this single assessment, statistically significant. And we did not see an increase in HDL that followed it. We went back to the charts of these patients that we pulled to try to figure out if there were any risk factors that might predict whether someone would have a larger increase in lipids versus not. And I think it was kind of striking. In the red, we see patients who had a family history of cardiovascular disease or a family history of a risk factor like hyperlipidemia. And these patients really clustered over on the right with higher or with greater changes in total cholesterol. And interestingly, patients who had underlying CF liver disease, they kind of clustered on the left. So they perhaps had a smaller or even a decrease in total cholesterol. So we were certainly not alone in looking at this question of modulators on lipids. So over a couple of years, we see 6 different studies, including ours, that looked at this question. What these studies have in common is, first of all but one is retrospective. So we're going backwards to see what has happened. Basically, all of them are looking at a single time point after initiation of modulators, and all of these are focused on the effects of ETI. What we see, though, however, that the message was pretty clear and pretty consistent that there was indeed an increase in total cholesterol and LDL in the range for total cholesterol of maybe 15 to perhaps mid-20s milligram per deciliter after starting modulator. So you might ask, well, okay, that's a pretty clear, consistent message. Why go forward? Well, I think the data that we had on hand is limited in a couple very important ways. One, as I said, it's largely retrospective data, and so there's certainly a high risk of sampling bias, as we saw in our population. This was not an average CF population. We're probably measuring lipids in people at higher risk for having problems. The second limitation is that the data really was not longitudinal. So we don't know if patients starting a modulator might have a bump in lipids or cholesterol that then plateaus over time, and we don't really have to worry over the long term. Or is this a progressive increase in lipids that would be much more worrisome? So it's clearly very difficult to do a prospective study these days, as most patients are already on highly effective modulators. And so our solution to address this was to turn to the CFF biorepository. So there was a couple of very interesting sample sets in the biorepository, one from the GOAL study and one from the PROMISE study. Unfortunately, the PROMISE study, which studied ETI, those samples were not yet available to us, so we made the decision to move forward with the GOAL samples. And so we hypothesized that initiation of ivacaftor would progressively increase lipid levels over time. So just a little background and reminder of what the GOAL study was. This is an observational study, initially in patients with just a G551D mutation who are being started on ivacaftor. That mutation panel was broadened a bit later on in the study to include other gating mutations in R117H. Samples were collected prospectively over time at defined time points and stored in the CFF GOAL biorepository. We were able to collect samples from 50 subjects who had serum samples at all of the 3 time points that we were interested in. So baseline, 3 months after starting ivacaftor, and 18 months after starting ivacaftor. And we simply measured lipid panels in those samples, but also did a directly measured LDL, as most of these were non-fasting samples. So this basically tells you what I just told you, but I'll just point out we did have a little bit of clinical data, but not a ton. So we know the patient's age, sex, their genotype, their lung function, whether or not they had CF-related diabetes, whether or not they had CF liver disease, and their BMI. At baseline, not much information thereafter. So this is the characteristics of the population. So it was balanced from perspective of gender. About 38% of patients were actually pediatric, so in the 12 to 17 age group, and 62% were adults. Baseline BMI was 21.2. 28% of patients had CFRD, 12% had impaired glucose tolerance, and 60% had no diagnosis of CFRD or IGT. And the vast majority of patients were predicted to have severe disease based on their genotype. So what did we find? So here we see the lipid values at baseline and at 3 months, and indeed we did see an increase in total cholesterol and a trend toward increase in LDL at that 3-month time period. Interestingly, though, when we move out to the 18-month time point, we did not see a further increase in total cholesterol or ADL, and in fact, if anything, perhaps a little regression back toward the baseline. So what else was going on with patients? They were indeed improving lung function with therapy. They were gaining weight, as you can see here. And when we went back to do analyses that adjusted for important covariates such as age, sex, BMI, this difference between baseline and 3 months in total cholesterol persisted. And we saw a nearly significant difference with LDL. We also learned that BMI was a significant covariate for cholesterol, so patients with higher BMIs had larger changes in total cholesterol. So what are some of the initial takeaways from this study? So in what I would describe as perhaps a more typical risk CF population, as opposed to what we probably sampled in our retrospective work, total cholesterol did indeed significantly increase 3 months after starting ivacaftor, but by 18 months, the lipid levels were no longer significantly elevated. And so perhaps when we qualitatively compare different studies, perhaps the effect of ivacaftor at least looked smaller than what has been reported with ETI to date. So there are a number of limitations and some possible explanations for what we observed. One, we don't know if patients, as they were gaining weight, may be modifying their diet in response to the weight gain, and that certainly could impact our data. We also had very limited clinical data after baseline, so medication changes, other clinical changes could have impacted our data, and we're kind of left to ask the question, is the perhaps smaller impact on lipids that we saw in this data set due to the fact that we were studying patients started on ivacaftor as opposed to ETI, or was it that this population is different than what has been published in retrospective analyses? We do have a bit of data from PROMISE, however, although we didn't have the samples, and this was presented in poster format last year. And this came from the PROMISE endocrine sub-study. In this sub-study, samples were taken fasting at baseline and then 12 to 18 months after starting ETI in 51 patients. And this was a relatively young population, so the median age was 17 years of age. And while there was a significant increase in total cholesterol, LDL, et cetera, once again, you can see quantitatively it was a relatively small increase, so 7 milligrams per deciliter for total cholesterol. Before we get too reassured by these data, I think I want to show you one other study that was published 2 years ago from Carnevale et al. And this was a group of 20 patients who were studied longitudinally at baseline 3 and 12 months after starting ETI. And what they saw was a much more progressive and perhaps worrisome increase in lipids. So as you see, LDL in particular started at 47 and was at 91 by the end of a year in a more progressive fashion. So what are the next questions for this topic? One, I think, is mechanisms. So is this related to increased cholesterol and lipid absorption through the gut after therapy, or might this be related to increased cholesterol synthesis in the liver? There are a couple papers in the literature, and they're actually a bit contradictory, so I think this remains really an open question and open for future study. Probably even more important is what's the clinical impact of these changes in lipids. Some have viewed this perhaps as a favorable kind of correction of hypolipidemia, but certainly this may also be an additional risk factor for coronary disease. And so to summarize, we did see an initial increase in lipids that did not progress further through 18 months. And I think the literature remains unclear, so we have to put all of this in context to all that has been published. And it may depend on the modulator that's being used, but it also may depend on the study population as well. And I think ultimately longer-term data is going to be very helpful. It'll be nice to untangle some of the mechanisms of lipid changes, but I think really more research is going to be needed to understand these long-term clinical implications of lipid changes, so that we can then translate these into updated guidelines for screening and treatment. So with that, I'll thank you very much for your attention. Thank the CF Foundation for funding.
Thank you. We do have one question for you from the app. Did you have patients with pancreatic sufficiency or control for pancreatic sufficient versus insufficient?
Yeah, that's a great question. We really had to rely upon genotype to try to make an estimate of this. So 88% of our patients would have been expected to be pancreatic insufficient. There were a couple of patients who are R17H who probably were pancreatic sufficient, but very few.
Thank you so much for your presentation. I'm Senthil Sankaraman from Cleveland Clinic, Cleveland. Both the data from PROMISE and then the subsequent study you showed, it's interesting to see in PROMISE the HDL did significantly go up, which may go in favor of the absorption hypothesis, versus the other study more kind of like the opposite way it went down. Yeah, thank you.
Yeah, thank you. Yeah, I wish I had an explanation. I really wanted to point out really the differences in the literature, so that we're not overly confident and overly secure where we're at today, because I think we need more research to better understand this.
Yeah, that kind of implies that it just multiple mechanisms are kind of like involved in it, right? Yeah.
I think it's an open question.
Thank you.
Hi, Mitch Ramsey from Ohio State in Columbus. I appreciate your sort of thoughts on the possible mechanisms that might be explaining this. And I wonder if you can speculate on potentially the role of diet contributing to this as well. I know at our center, when we start modulators, we really harp on the need to take the modulators with a lot of fat. And in my experience, that rarely looks like avocados and nuts. And oftentimes involves, twice daily trips for fast food. And so I wonder, are you aware of any data that sort of looked at in tandem with the pre and post lipid panels, some pre and post food frequency questionnaires or some kind of marker of?
Yeah, I'm unaware of any actual data to let us know whether people are actually taking in more fat because they're on a modulator or not. My gut feeling has always been, they're already on a high-fat diet. It's more organizing when they take their medicine rather than changing their diet to a higher fat diet. But no data to support that speculation.
Hi, Jessica Alvarez, Emory University. Thank you for that. I was curious to know if there's any data on like bile acid metabolism with ATI.
There probably is. Mike, I saw you before. You can tell us. There's the data that's, I think, related to mechanism. So there are, this is the data that I was referring to that's a bit contradictory. So from the same group, patients who were homozygous for Delta 508, they measured levels of plant cholesterols versus endogenously synthesized, and saw one pattern. And then in patients who were heterozygous for Delta F508, saw the opposite. And so I am left putting my hands in the air, so I don't know. I think it's a good approach to try to sort out, mechanism. Is it absorption versus synthesis? But I think it's uncertain at this stage.
Good. Thank you for this. Very interesting, and I think very much a part of what we've got to figure out, the lipid story. Just to add, we had a small study in children where we did document increasing fat intake. I think it was with ivacaftor, both in the US and Italy, because we actually had an Italian cohort. And we've got a couple of papers, again, in younger children, when we were looking at the nutrition impact as the new drugs came on the market, where we have some report of bile acids. So you can look at that, but much younger cohort than, and unfortunately, in none of those studies did we do lipid panels. Okay. So regret that now.
No. But thank you for adding that. I appreciate it. Again, my main disclosure is I'm a pulmonologist. So the least informed person in the room, probably.
I have another question for you. How was the presence of family history of heart disease assessed?
So this was chart review and just, again, Dr. Desplata is doing the work, of course, but going through all of their records to look for just, from the records, a family history of coronary disease, a family history of hypercholesterolemia, a family history of hypertension, and just collecting it that way.
Great. Thank you very much.
Thank you.
Yep. All right. I will present our next speaker. Angshita Dutta is a research scientist at the University of Washington Department of Pediatrics in Seattle. She completed her undergraduate degree in microbiology and human rights at the University of Washington before getting her master's from Western Washington University, also my alma mater, in molecular and cellular biology. Currently, Angshita is researching gastrointestinal clinical outcomes in multi-center studies BEGIN and PROMISE in the lab of Dr. Lucas Hoffman. And in her free time, she enjoys attending a wide variety of dance classes and is interested in attending medical school in the near future. Thank you for being here, Angshita.
Hi, everyone. Thank you all for being here, and thank you as well to the organizers for inviting me today. I will be talking to you about changes in fecal elastase results from the BEGIN study. So I want to start out with a broad overview about what exocrine pancreatic insufficiency is. So EPI is the inability of pancreatic enzymes to enter the small intestines. We had a nice review of this in that plenary last night, but if you remember, pancreatic enzymes exit pancreatic ducts into the small intestinal lumen, and then they help to break down food into smaller molecules that our body can consume. So unfortunately, most people with cystic fibrosis have EPI at birth. And because it's seen at birth, it suggests that it's happening in utero and then that the pancreatic damage is accruing over time. So clinically, EPI can cause malabsorption and the maldigestion of food without the enzymes present to break down carbohydrates, sugars, and fats, which can lead to several clinical consequences. Patients can get really large, bulky stools that can cause intestinal obstruction, as well as really fatty stools called steatorrhea. And there's also nutrient deficiencies that happen due to a lack of fat-soluble vitamins without the ability to break down fats. So these contribute to poor growth and poor weight gain, and overall a failure to thrive in children who are born with EPI. So currently, the therapy for EPI is oral pancreatic enzyme replacement therapy, or PERT. And while PERT is great for alleviating some of the downstream symptoms like intestinal obstruction or steatorrhea, it doesn't actually completely reverse EPI or address the root cause of the pancreatic damage. So the way that we look at EPI in a laboratory setting is by looking at stool samples, and specifically we look for the fecal elastase, which is a biomarker for pancreatic function. So what we do is we take these stool samples, run them through a few washes and buffers and some general agitation, and then we toss them into an ELISA assay. So as many of you already know, an ELISA assay is coated with an antibody, which then binds to fecal elastase. We then have another antibody that has a dye on it that fecal elastase will also bind to, and then we're able to quantify the levels of fecal elastase in each of our individual stool samples by measuring the optical absorbance. So as you can imagine, having high numbers of fecal elastase would be indicative of having normal pancreatic function. However, what we see in people who have EPI is low or mid levels of fecal elastase in their stool samples. So with the advancements in CFTR modulator therapies, it begs the question if improving CFTR function through modulators could help restore pancreatic exocrine function. So I want to talk about a few different papers that address this question before I get into our BEGIN data. The first paper I want to talk about is the ARRIVAL study, which looked at children 1 to 2 years old, and these children tended to have less severe EPI than the ones in the BEGIN study. And these children were treated with ivacaftor, single modulator therapy, and then followed for 24 weeks with repeated sampling. So here on the y-axis, we have levels of fecal elastase, and on the x, we have the day at which the sample was collected. And I just want to direct your attention to the right side here. That's indicating anything less than 200 micrograms per gram of fecal elastase in the stool is indicative of exocrine pancreatic insufficiency. So these researchers saw that overall there were increases in fecal elastase. At baseline, levels of fecal elastase, the average was 182.2, whereas by week 24, the average was 326.9. And I just want to point out here that this baseline of 182 is significantly higher because these children than those in BEGIN, because these children had less severe EPI. So the next studies I want to talk about are QE and CLIMB, which looked at children 2 to 5 years old that also had mild EPI and were also treated with a single modulator ivacaftor therapy. But these children were followed for even longer, up to 84 weeks with repeated sampling. So here on the y-axis, again, we have fecal elastase, and on the x-axis is time. And for the first 24 weeks, we saw a similar increase to the ARRIVAL study. And that increase in fecal elastase did continue over an 84-week period. Lastly, here we have the PROMISE study, and this is, as we just heard, in adults and adolescents over the age of 12. And these people generally had more severe EPI than those in the ivacaftor studies I just talked about. These people were also treated with triple modulator therapy, ETI, and then followed for 6 months. And what these researchers found was that at baseline, 100% of their participants had abnormal levels of fecal elastase, and by 6 months, 98% of them still did. So these researchers concluded that there really wasn't any significant change in fecal elastase after 6 months of ETI therapy in adults and adolescents. So just to summarize here, in young children that had mild EPI given single modulator therapy, there were continual increases in fecal elastase seen past 6 months up to 84 weeks. However, in adults and adolescents over 12 years old that had severe EPI given triple modulator therapy, there was no significant change in fecal elastase seen over a 24-week period. So the PROMISE researchers in this study thought this might be due to the age of their study participants. So the BEGIN study gives us the opportunity to look at young children who have severe EPI and ask the question if EPI is more reversible in young children than in adults. And because of what we saw in the ARRIVAL, QE, and CLIMB studies in younger children and increases in fecal elastase, we hypothesized that the fecal elastase levels will improve in young children, even though they have a copy of the F508del mutation. So the BEGIN study is an observational study that's measuring outcomes before and after ETI therapy in children with cystic fibrosis that are 2 to 5 years old and have at least one F508del mutation. Our study subset included 75 of these children that had fecal samples collected at baseline and 6 months after initiating triple modulator therapy. Specifically, we had 47 people who were homozygous for F508del and 28 who were heterozygous. Overall, we had a roughly even number of females and males in our study population, as well as an average age of 4.15 years. And as you can see from the height, weight, and BMI percentiles here, most of these children hovered around the 50th percentile mark, indicating that they were relatively healthy at baseline. Also, 96% of people at baseline were given PERT therapy, and if you can recall from the beginning of my talk, PERT is often prescribed when there is exocrine pancreatic insufficiency. So the way that fecal elastase is categorized clinically is from the kit itself. So we use the Shibo ELISA kit, which had these three following categorizations for fecal elastase levels: severe, moderate, and normal. Then we used a paired t-test to compare fecal elastase levels pre and post 6 months of ETI therapy. So here on the y-axis, we have the elastase, and on the x-axis, we have our study population at baseline and month 6. So anyone that fell between 0 and 100 micrograms per gram would be clinically identified as having severe exocrine pancreatic insufficiency. Anyone that fell between 100 and 200 would have mild or moderate pancreatic insufficiency, and anyone over 200 micrograms per gram would be identified as having normal pancreatic function. So at baseline, our average was 95 micrograms per gram, and by month 6, that average was 125 micrograms per gram. So even though we see an increase in the average after 6 months of ETI therapy, it is probably important to say that this increase likely doesn't have any actual differences in clinic in terms of nutritional absorption. Then we wanted to look at what the changes in fecal elastase levels look like by genotype. So we looked at heterozygotes and homozygotes, and we saw that heterozygotes had a 4.4-fold increase in their fecal elastase levels at month 6 compared to baseline, whereas homozygotes had a 1.7-fold increase in their fecal elastase levels at month 6 compared to baseline. So overall, we saw smaller changes in fecal elastase levels in homozygotes compared to heterozygotes. So after looking at those population changes, we wanted to identify some of the individual changes in our study population. So this bar chart here is identifying the percentage of people in normal, moderate, and severe clinical category at baseline, as well as month 6. And then we use an alluvial plot to identify what individual changes between these categories look like. So overall, we saw that 8 people had improvements in EPI category. Specifically, 4 people went from mild, moderate insufficiency to normal, which you can see here in this orange line. And we had 2 people who went from severe insufficiency to mild moderate insufficiency, as well as 2 people that went from severe insufficiency all the way to normal. Lastly, we had 3 people that decreased to a more severe category. And while these individual changes are really interesting, I do need to point out that most of our study population ended in the same clinical category that they started in, and that most of them stayed within the severe category. So there are some limitations to our study. We have a somewhat limited sample size with an N of 75, and we don't have a placebo arm in our study. So that means that everyone in this study was given ETI and knew they were having ETI, and we didn't have an age-matched control group. So that means that we cannot say that these results are 100% due to ETI therapy versus just the normal fluctuation in fecal elastase levels. Lastly, we had a relatively short timeline. These are preliminary results from the BEGIN study, and the BEGIN study will include longitudinal sample collection up to 60 months. So overall, we did find a statistically significant increase in the average fecal elastase levels at month 6 compared to baseline. And we saw that the average change in fecal elastase was smaller in homozygotes than it was in heterozygotes. Lastly, we saw that more people improved in EPI clinical category than worsened. And specifically, we had 8 people that increased and 3 people that decreased. So overall, we can conclude that CFTR modulation did improve fecal elastase levels in a small subset of our study population, even though they had one F508del mutation. But there are still some questions that remain. So from previous studies in young children that had mild EPI, where we saw fecal elastase continue to increase over time, it begs the question if benefits from modulator therapy can accrue over time. And in the PROMISE study in adults that had moderate to severe EPI, where they saw no changes in fecal elastase, it's exciting that in the BEGIN study, the data that I just presented, young children with CF that had moderate to severe EPI, we did see an average increase in fecal elastase at month 6 compared to baseline. So is EPI more reversible in younger children than adults? For the future directions, sample collection will continue in the BEGIN study up to 60 months. And this will be really interesting to see because from the QE and CLIMB studies, we know that when the increases in fecal elastase were seen within the first 6 months of study, those increases continued up to 84 weeks. So longitudinal understanding of what's happening with fecal elastase is going to continue to be important and informative. I think it'd be really interesting to continue including younger children as they become eligible for ETI, including infants or neonates, since we know that EPI is beginning in utero. Lastly, we can conclude that our findings suggest pancreatic function may be rescued, at least partially reversible, in some small subset of children with CF. But further investigation for the clinical significance of this is still needed. A huge thank you to everyone in the Hoffman Lab and Colin O'Rourke, who is responsible for many of the statistics in this project, as well as the BEGIN study personnel and all of the participants in BEGIN. Thank you all so much for listening to my talk.
Great, we will take questions if you want to come to the microphone or put them in the chat. To start us off on your last slide of future directions, what are the future directions that you have planned for BEGIN, or what type of population, what size?
Yeah, so BEGIN Part A had 130 participants and BEGIN Part D had 220 participants. And the goal of the study is to look at GI, pulmonary, and growth and how they change after ETI therapy. Yeah, in young children, so 2 to 5 years old.
Hi, Catherine Cutney from Case Western in Cleveland. A very basic question about fecal elastase and about the variability. Do we know if the variability we see is an assay issue? Is it a sample to sample issue? Like if you get a stool sample one day and you get one the next day, are those going to be different? And if they come up with different results, are they actually different, or sometimes is it just a sampling problem?
Yeah, no, that's a really good question. So all of the results that we presented today are within the inter and intra-assay variants within the kit. So those are outlined by the kit, and all of our data points fall within the variants. Yeah.
Hi. I don't know if you recognize me from Zoom or not. Good job. That was awesome. And I know I'm supposed to know the answer to this, but do you remember if we looked at the people who had null mutations as their second mutation versus other mutations as their second mutation? Did we pull that out? I can't remember because I should know.
No, that's a good question. So I didn't have access to all of the mutational data, so I'm not sure, but it definitely would be really interesting
I'll pick
to
on
know.
Luke. It's okay.
Yeah.
Okay, we have a question in the chat. Can you comment on the number of patients that went from below limit of quantitation into the measurable range?
Oh, that's really interesting. Yeah, so the range for the kit is 15 micrograms per gram to 500 micrograms per gram. And I'm not sure how many people were at the bottom baseline of that, but I do know that there were less people at baseline at that bottom detection level at month 6 than there were at the beginning of the study.
Okay. We have one more question for you. So as many of us know, there are case reports of women using modulators during pregnancy when the fetus is identified as having CF. Could this potentially be added as a cohort in the BEGIN study population?
Yeah, I think that's a super good question. Definitely it's been shown that moderators have been safe for pregnant women so far. I actually don't think that they would be included in the BEGIN study just because the BEGIN study is focused on young children that have CF. But I do think that neonates could be included in the BEGIN study in the future.
Oh. No, okay. Well, let's go. Well, congratulations on getting close to enrollment goals. So, okay.
Thank you, Angshita.
Thank you so much. Very well done. All right, our next speaker is Dr. Jeananne Stallings, who is a professor of pediatrics at the University of Pennsylvania and serves as the director of the Nutrition Center and faculty of the Division of GI, Hepatology, and Nutrition at Children's Hospital of Philadelphia. Her research interests are the nutrition-related growth and body composition abnormalities in chronic childhood diseases. CF research to improve clinical care for children and adults has been a career-long commitment, and she recently received the inaugural Partnership of CFGI and Nutrition Award. She's a fellow of the National Academy of Medicine and has contributed to many reports that are related to nutrition and public health. Thank you for being here.
Thank you very much, and I'm delighted to be here. And say it's wonderful that we're all here on Saturday morning, yes. And thank you for the invitation and putting together the kind of program that would tempt us to be here and do all of this. So it's been a great meeting, and I look forward to sharing some information with you. The disclosure slide, the funding for this primarily came from Chiesi and through an investigator-initiated study award, but also to recognize one of the investigators was supported by the NASPGHAN Nutrition Fellowship, which we appreciate having for our GI fellows. The malabsorption blood test that I'll talk a little bit about has been developed at CHOP, and to mention it was internal funding, but also a pilot and feasibility award from the CF Foundation and Solve Pharmaceuticals. And then you have the consulting kind of disclosures. So in the way of background, the issue of acid-reducing medications, I think it's been getting more and more play. We didn't even think about that probably a few years ago, But as even during this meeting, there have been a number of other sessions where this has come up. And all of you know that, the logic behind this is if we improve the acid or the pH environment in the upper small intestines, that this would help improve the efficacy of the PERT enzymes. And that, in fact, if you had a less acid or higher pH, that the lipase would work better, and we would get more fat absorption, and that would go on to improve the calorie intake and ultimately nutritional status. Now, there's been a list of investigations over the years, and I'm not going to take the time to go through them, but to suffice it to say that you have some that made it look like this did work and it did improve absorption. Another group of 2 or 3 studies in each of these that was equivocal. It didn't go one way or the other, and a couple of studies that suggested that it might help. So the literature showed interest in this topic, but certainly not, if you will, the whole collection of data headed in one direction. So our aim was to look to evaluate this straightforwardly, prospectively. The PPI, the protein pump inhibitor we used, was omeprazole at 20 milligrams a day. That is the typical drug and the most typical dose used in CF. And our approach was to have a randomized, placebo-controlled, double-blinded study. Even though it was a pilot study, we were very interested in doing the best study we could. The placebo was a capsule that was made to look just like the omeprazole, and everybody was blinded. The participants were people with CF that were at least 12 years old, with a history of having pancreatic insufficiency, a history of taking PERT, and the fecal elastase measurement was less than 200, so for the enrollment. One of the strengths of the study really is that we approach fat absorption or malabsorption in 3 independent ways. And our group has really been very interested in this issue of fat absorption and the difficulties of actually measuring this accurately. So you know that the coefficient of fat absorption, the CFA, is the classic method where you collect all of the stool from your participant for 3 days, for 72 hours, and you also collect, in the research setting, a weighed diet record of what they consumed during that time. And this is still the method that's used by the FDA when evaluating pancreatic enzyme efficacy. We've always used the Mayo Clinic laboratory to do the analysis of the fat in the stool. The next method was what is the wireless motility capsule. The trade name was Smart Pill. And this is something that is not a camera, but a small capsule that you swallow, and it gives you readouts over whatever your transit time is the next day, 2 or 3, until you actually excrete the Smart Pill. And it had the advantage of not only did it give you pH, which is what we were interested in, but also temperature and pressure. So it's of interest to people who do motility studies as well. And then lastly, we use the malabsorption blood test, which we've developed. So to give you a little bit more background on this, as you all know, a dietary free fatty acid goes into the stomach and intestines and is pretty much immediately absorbed. It's a free fatty acid. It doesn't have to be digested. And then it doesn't have to really be a part of a micelle to be absorbed. So that was that's our sort of founding principle. We selected to use fatty acids that have odd chain length. So instead of the fatty acids that we're accustomed, that are C16s and 18s and 20s, and we did this because they're very low in the diet. And so they're also very easy to detect in the plasma, making the analytical part a little more straightforward. Our free fatty acid was a 15-carbon fatty acid called pentadecanoic acid. And then the triglyceride, so the free fatty acid, the triglyceride is the triheptadecanoic acid. So this is the triglyceride backbone with three 17-carbon length, fatty acids. So the PA, free fatty acid, is rapidly absorbed. The triglyceride has to be digested by lipase to yield the free fatty acids, and then they have to go through and be in a micelle and get absorbed, get across the gut and into the blood. We use these in a test meal, our breakfast test meal. I can think of it as a little like chocolate milk or small milkshake. And blood sampling was, of course, before the first dose and then followed in the experimental situations for 9 hours. So to show you this, to get a visual of what this is really one of our proof of principle studies, and you can see published over 10 years ago. And lipase inhibitor drug, orlistat, was a drug that came out really as an obesity treatment. And what we show you here is 15 healthy subjects. And on the left, you see the PA, the free fatty acid, and you see them on the orlistat or off of the orlistat. And those lines are pretty much identical. And then if you look on the THA, the triglyceride that gets digested to the fatty acids over a longer time, you see the difference when they are on the orlistat or not. So the yellow line is untreated, and then the black line at the bottom shows really almost a complete block of the absorption. To put it more back in our domain, this is a study that we published a while back where we did the malabsorption blood test in a group of patients with CF and looked at them by pancreatic status, sort of what we were just talking about. As early drugs came to market, what did we learn? Over on the right, the pancreatic sufficient group, you see the HA, that best marker of digestion and absorption area under the curve, which is the analytical approach, was 16.7. And the patients who had pancreatic insufficiency had the HA that was 11.3. So in CF, it was also informative. So for the study at hand, we enrolled the patients. If they were on a PPI, they had to wash out, and then they were given the PPI for 28 days. Following that, they came back for another visit where they had the MBT and the wireless capsule. The day after that finished, they went into the 3-day diet collection. Then randomization, a washout, and then back into treatment with whatever the new drug was or placebo, and visit 3, again with the same protocol, and ending with the 3-day collection. So I appreciated Sarah Jane mentioning it. We did this study right in the middle of the COVID disruptions, and we were able to continue, but certainly there were disrupted. It was very hard to get people to think about clinical research during that time. So we enrolled 19 subjects, but only 13 were randomized. And here I have just the summary of the fat absorption methods. In the CFA method, we only had 3 people who were able to complete the diet and stool collections. And the results was 1 showed an increase, 1 showed a decrease, and 1 showed no change. In the malabsorption blood test, we had 9 participants with paired results. 2 showed an increase, which is what you would expect if the PPI were working, and 7 showed a decrease. And in the wireless motility capsule, we had 4 participants who did the study twice, and there were no changes. Also to mention, we did do some patient-reported outcome collections using quality of life domains from PROMISE, and there were no changes in that. So just to show you what the smart pill kind of data look like, here you see over 30 minutes, and the very low numbers over on the left are when the pH capsule is in the stomach, and the pH is very low, down at 2 to 3. Then you see over just a few minutes, it passes from the stomach to the small intestines, pH comes up and stays at about the same level over those 30 minutes. And there really are no differences between the on and off PPI, according to our collaborators who are the experts in this. And then because we had the data, we wanted to also look at the transit profile, because we do believe from other work that there have been some abnormalities in gut transit time. And again, there are no differences here looking at the different segments, the stomach, the small bowel and large intestine put together, the colonic transit time, and then the last figure is the total whole gut. So in conclusion, I am really presenting a small pilot study and presenting it really descriptively because the team felt it was much too small to really think about statistical evaluations. You did use 3 independent measures, which I think, again, adds strength to this. And the results really suggest at this preliminary stage that PPIs do not improve PERT-related fat absorption in cystic fibrosis with pancreatic insufficiency. Of course, the next step is we need a larger RCT to really evaluate this and be a definitive trial, because I think we all are very interested in this drug had, if you will, utilization creep in cystic fibrosis over the last 10 or 15 years. And we'd like to know, when we think we're giving it to improve PERT efficacy and absorption, is that true or not? Now, the other thing is certainly to say that plenty of our patients have reflux, and PPIs are the best drug for that, or maybe not the best drug, one of the drugs. The other background of all of this is it's really become evident over the last few years that PPIs as a drug class have a number of potential adverse events over time. And I think all of us in the GI and nutrition world are trying to think about to get the right best drug and for the right amount of time. Our CF patients thinking about malabsorption, we're on this for years. The classic treatment for acid reflux is to treat somebody for 3 weeks or something like that. So again, we really need to think about this differently. So thank you for that.
Thank you, Dr. Stallings. That was great. I was thinking about that last point that you made about the long-term implications, and just wondering if there's any data on PPI and bone health, and especially as we think about our aging population, our
Right.
UCF population.
Well, there are no data in cystic fibrosis, but there certainly are. That's one of the things that's come out that's associated with lower bone mass in people who've taken PPIs over time. And that, I think, was like one of those eureka moments over the last few years when we realized what we were doing. Yeah. No.
Thank you, Dr. Stallings, for such a great presentation. I have a question about the malabsorption test you alluded. The C15 or the pentadecanoic acid, can that be part of triglyceride?
Can that be part of
triglyceride, or it always?
Okay, that's a good question. Well, it rarely is. I mean, part of why we chose this is those two fatty acids are very low in our diet. In fact, they're almost exclusively in dairy foods. So odd chain fatty acids just aren't in our food supply very much. And one of the things I didn't mention is there's a 24-hour exclusion for dairy foods before you do the NBT. And with that, it may not have been as obvious, but the baseline measurement is almost zero. So that was the strategy. And they're so low in the blood system, except in our testing environment, I don't think they would often be in triglycerides because they're not in the diet.
Definitely much easier than 3 days stool collection. So.
Absolutely. That's where we're going. Thank you.
Thank you, Dr. Stallings. That was fascinating. A couple of questions, and apologies if you said this. Were the subjects that you had in both arms naive to acid blockers before, or could the two arms have differed in their history of PPI use or other acid blocker use?
No, that's a good question, and I should make it clear. If somebody had been on PPIs, there was a washout period before they ever enrolled. And then each subject was randomized to both arms. So we have the within subject change. And then the 28 days. So the washout was very important because partly, I mean, we didn't want that as interfering, but that was also a way of reassuring the patients and the doctors that we were, going to see this all the way through.
Okay, thank you. Second question. In the smart pill data that you showed, I might have this wrong too. I don't know if the gastric pH measurements are accurate, but it didn't look as if there was a difference in gastric pH among the treated and untreated patients. Was that true?
That there was no difference between the treated and untreated at any level. So that's a good eye, because part of what we really are coming back to is maybe even the primary use of PPI in CF and at a 20 milligram dose, because we sometimes use higher doses for people who have terrible reflux. But one of our surprises is that even that didn't look that different.
Tom Ziegler from Emory. Great talk, Dr. Stallings. Just a little bit of an aside question, somewhat related to your topic, but you'd be the expert to know. So PPIs can cause disruption of the gut microbiome, at least in the proximal area.
Right.
And people with CF, I believe, have dysbiosis anyway. So there's a lot of bad bugs floating around all over the place. And they can affect macronutrient absorption, of course, including lipases and stuff. So, like, where are we with, like, gut microbiome? Sorry, I guess it'd be better empiric or didactic treatment of bacterial overgrowth. And do you think that those measurements should be done in studies such as this to kind of rule out that possible confounding factor?
So again, I think that's a good question, and there are all sorts of people working on the microbiome in CF, the respiratory, the stomach, the whole gut, and you're right, there are abnormalities, and probably from the CF itself, certainly from all the antibiotics that they get, and that sort of thing. And we do have patients who have bacterial overgrowth and address that. None of our patients had bacterial overgrowth to the clinical eye. We didn't test that as part of inclusion. But, that is something we all have to keep in mind. I don't think in the upper small intestines that the microbiome has that much to do with macronutrient absorption. I think in CF, we've always been more worried about, the little extra mucus on this, that goes with the water balance problem and the inflammation. And some of the interesting stuff on the new drugs are helping inflammation by looking at that. So lots of things, but the microbiome, I think, is being well studied, but probably not that related to this.
We do have one question for you from the app about PERT. Did you control or look at the difference if PERT included bicarbonate versus PERT that did not, and the impact on results?
Right. All of this did not include the bicarbonate medication, so we couldn't address that.
And I have one question for you that was similar to what I asked Dr. Schwarzenberg as well, which is, especially with an investigator-initiated study that isn't as bright and shiny as some of the TDN studies or industry-sponsored, how can dietitians partner with your clinical research team to help with potential participant recruitment and retention?
Good. Well, almost everything with CF now goes through TDN review and commentary. And even if it was not registered as a TDN trial. So the supervision, I think, is there. I would work, well, and to finish on that thought, from, I think, a scientific integrity point of view, and certainly from our IRBs, investigator-initiated is dealt with as an independent trial, although it's certainly disclosed. Very different from a contract or something like that. But I have always relied on my CF dietitians, and many, not this study, but many of the studies we've done, we've recruited from 10 to 15 centers around the country, even, as you heard, some in Italy and some in Canada. And I find the relationship between the dietitians and the camaraderie essential, because in essence, those are the people who are talking to each other sometimes and going, should we really try to go find some people for this trial? And I think the relationship is very solid with the dietitians and research across the board. Our stuff is a little bit different from the traditional medications because those are thought to be primarily pulmonary stories. I think everything that's going on with new enzyme development, our kind of thing, dietitians are right in the middle of it. And I certainly appreciate it.
We appreciate you.
Okay. Thank you very much.
Thank you, Dr. Stalling.
Thank you. Okay, our last speaker, Dr. Jessica Alvarez, is an associate professor of medicine in the Department of Medicine, Division of Endocrinology, Metabolism, and Lipids at the Emory University School of Medicine. She is a registered dietitian with a PhD in nutrition sciences and a master's in clinical nutrition from the University of Alabama at Birmingham. She has expertise in human studies of nutrition, body composition, and assessment of human metabolism, and is the principal investigator for the CFF-funded National Multi-Site Strong CF Study. An overarching goal of her research program is to gain a deep understanding of the role of diet and nutrition on CF clinical outcomes. Thank you very much for being here.
Thank you, guys. Just a quick clarification. I'm one of other principal investigators on the study. Okay, quick show of hands. I would love to know how many RDs are in the room right now. And I would love to know how many of you participate in research. Okay, this is great. It's a lot of you. I'm very excited about this. So this might all be not new for you, and maybe we can just have this big welcome party talk for this one to end. Well, I know there's still more sessions left to go though. Disclosure. I won't harp into these. We've seen these slides. The landscape of nutrition and CF has really, truly changed with prevalence of decreased prevalence of undernutrition, increased overweight, obesity. We are finally starting to really talk about diet quality over diet quantity. Very exciting. We've shifted the thought from BMI understanding. It's great as a screening tool, but moving more towards body composition assessment. We've seen this throughout the conference. We've also recognized that we need to move away from general recommendations for people with CF to individualized recommendations. So I'm showing preliminary data here from my collaborator, Dr. Ben Kopp at Emory, in children and adults starting a highly effective modulator therapy. And you see, this is percent change or BMI change over time. Not everyone has gained weight, and not everyone responds to highly effective modulator therapy the same. Also, I've said this before, not everyone can take highly effective modulator therapy. Dietitian Lucia Gonzalez Ramirez presented yesterday that there were differences in whether lung function was associated with skeletal muscle mass, and that depended on if you are on modulators or not. So you see here, the blue line, those not on modulator use, we see that relationship, the positive relationship that we expect, higher muscle, higher lung function. But those on modulators, that's a flat line. That just gives us thought to what outcomes we need to be looking at when we're thinking about nutrition. So what's ahead for nutrition research in CF? I really think old research needs to be revisited now. So we need a new baseline for our patients. How many calories, fat, proteins do we actually need? What dietary patterns do we need to be following? And going back to that previous slide, what is a good clinical endpoint for nutrition interventions? There are a lot of exciting new research questions that need answering. How do we treat obesity? Do we even need to treat obesity if there are no metabolic abnormalities? How do we optimize health for the aging CF population? So thinking back to individual recommendations, I think about precision nutrition, and the NIH defines this as considering multiple synergistic levels of influence. I'm just going to read from the slide for you. It considers dietary habits, genetic background, health status, microbiome, metabolism, food environment, physical activity, socioeconomic, psychosocial characteristics, and even environmental exposures, pollutants. And understanding the interrelationships among these factors will be critical for developing more targeted and effective dietary interventions. So in 2020, Dr. Francis Collins, a friend of the CF population and former NIH director, convened a team of experts, including Dr. Ziegler, who's here today, to put forth a strategic plan for NIH nutrition research by 2030. And it included multiple avenues. So one was to spur discovery and innovation through foundational research. I'm thinking the research that Dr. Stallings just presented on using these cool AI tools, the smart pill, investigating the role of dietary patterns and behaviors for optimal health, defining the role of nutrition across the lifespan. We see our aging ACF population, but not only that, the baby boom that we're having. How do we feed our pregnant mothers, our infants, and reducing the burden of disease in clinical settings. There are also, as part of this plan, several cross-cutting research areas that are really important to CF as well. Minority health and health disparities. We know that cystic fibrosis does not only occur in Caucasian populations, it occurs in all populations. And the CF Foundation has really made amazing pushes to help reduce the ethnic health disparities we see in CF. So this addresses things such as food insecurity that we've seen. Dr. Juliana Bailey has addressed some of these. Also thinking about culturally appropriate dietary recommendations. We all love the Mediterranean diet. I love it. But it's really mostly, I would say, a very Caucasian-based diet. And we know that there are ethnic foods that can be just as healthy, traditional foods. So these are foods we need to promote, right? Data science, symptom science, and AI. We had a talk yesterday on nutritional informatics that was really great. And then training the scientific workforce. That's you, and Pee Wee Herman. So RDs are a critical member of the research team. I'm showing here Danisha Batchelder for our pediatric research team, Swati Zaveri on our adult, on my adult team. You guys have the training and the skills needed. You get critical nutrition assessment training. You know how to communicate. You know nutrition counseling. You can write. You know how to do presentations. I've seen you do presentations. They're amazing. And you know how to critically evaluate. You get training in how to critically evaluate the scientific literature. You have the qualifications. You go through dietetic internship, masters, you spend a lot of time in training. You guys, we are the experts in food and nutrition and what goes in, what we eat. So just thinking about some other roles for research specific, there are plenty of roles in protocol development, thinking about designing menus for all of these wonderful interventions that we're going to do to improve diet quality, right? How do we meet both study needs and dietary needs of our participants, but also what will our participants actually eat? I think about the story when I was in grad school where we had an investigator who's not a dietitian or nutritionist at all, tell us that they wanted a diet. They had a draft diet for this cohort in Alabama of adolescents. And on this draft diet, they gave us edamame and hummus and all these other things. And we looked at it and we were like, your people are not going to eat this, I promise you. You need to make this appropriate for your population if you want this to work. Study design development. What is actually feasible to do? What tools are best to use for desired nutrition outcomes? You guys know these. Also, design and data collection, case report forms. I get asked a lot, what kind of information do I need to be collecting for my nutrition study? What are the nutrition related labs that I need to be aware of? What medication supplement information should I be getting? You can advise and perform nutrition assessments beautifully. You know the difference and the limitations between 3-day food recalls, food frequency questionnaires, and 24-hour recalls. You trained in anthropometrics ad nausea. Newish, not new tools, but tools such as BIA and hand grip strength. You guys have the tools and can do this. Participant recruitment, that one's key, especially if we're thinking about clinical dietitians. You have access to these clinic patients and can identify them based on specific inclusion-exclusion criteria. You can speak to participants about study opportunities that might be coming up for nutrition and discuss any questions and concerns that your participants might have. And if you're formally part of the research team, conducting informed consent. So I have our Emory dietitian, Caitlin Baskell, who probably doesn't know that we rely on her a lot and she does, just to briefly mention our studies that might come in passing. It's wonderful. So you guys heard yesterday about Strong CF. This is a multi-site longitudinal cohort study aimed at finding the best clinical measures of nutrition status, sarcopenia, and frailty in CF. Dr. Schwarzenberg is one of our mentors on this one. And we're getting a lot of assessments. This is just a dabbling of the ones that I think are really related to what our dietitians can do on the ground: BIA, hand grip strength, administering the food frequency questionnaire, circumferences, skim folds. And I know, Alex, I heard you are a Strong CF coordinator, but Terry, I just learned that you were too. Are there any other dietitians in the room that are part of the Strong CF? Okay, well, maybe you are. You should ask. Fine. Get involved. We need you. You guys are, we were talking to an investigator the other way, one of the site investigators, and they were telling me that it was their dietitian who was really pushing them to be part of the study. This is your time to shine. This is it. This study, Jeananne mentioned earlier, people are used to doing FEV1 and getting spirometry and all that stuff. We won't do that. But they know how to, like the clinics, they know how to do spirometry. The study teams know how to do spirometry. This study has been it's been so fun, but a huge learning curve because no one was really doing all of these assessments and getting trained on how to do all of these assessments. So this is where you come in and can start to help and train folks. And maybe in 10 years, these are just going to be easy things to do, just like lung function is an easy thing to do now. I wanted to highlight one ongoing study that we have, Feed CF at Emory, and this is a randomized controlled trial. Several registered dietitians helped me in the design of this trial. We're randomizing participants to a usual high added sugar, high fat diet compared to low added sugar, high fat diet over 8 weeks. All foods are provided, and our outcomes are to look at effects on insulin secretion, sensitivity, visceral adipose tissue, and oxidative stress. Just to give you a little bit more, because we have a lot of dietitians, wonderful dietitians who've been involved in this. It's a 10-day rotating menu designed by a dietitian in Penn State, Amy Cicerella. All foods are prepared and shipped from our Emory Bionutrition Research Unit that is led by registered dietitians. Our initial calorie intake level is informed by indirect calorimetry and activity levels. And then we have weekly calls that I'll tell you a little bit more about, where total calories they're individually tailored to maintain body weight and adjusted as needed throughout the study. So these are some of our research dietitians. We are blind. I'm blinded to the study, and our study team is blinded. So our research dietitians are the one. They do a lot of the work because they're not blinded. They know who gets what. Our research dietitians at the Bionutrition Unit. They meet weekly with the participant by Zoom or by phone call to look over GI symptoms rating scale. I'd love to hear more from some of you guys whether this is a great skill or not, but just to review overall changes in GI symptoms, abdominal pain, heartburn. This was sort of our safety monitoring one. They monitor body weight, and then they work with the study physicians when someone does report an adverse event. So what can you do now if you're not doing research already? Just kind of things that you can do. Number one, hone your research skills. There are courses that you can take. I've listed some here that are free through our Georgia Clinical and Translational Science Alliance, but you have access to it as well online. So many of you work in academic institutions where maybe you get scholarships and credits to be able to take a couple of courses a semester. There are wonderful resources from the Academy of the Academy of Nutrition and Dietetics. I don't know if you guys know about this. I've been part of it for a while. The Academy of Nutrition and Dietetics has a research dietetic practice group that has wonderful resources. And then you can even consider getting certified as a clinical research coordinator. That costs money, I acknowledge that. But there are certifications that you can take if you really want to dig into research. Stay up to date on evidence-based research. That's key. And now, not just cystic fibrosis research, stay up to date on what's happening in the aging population, obesity, diabetes. Just a quick tip, you can actually get PubMed email notifications when something new is published. And you can set this to daily, weekly, monthly, however long you want. There are wonderful, wonderful abstracts downstairs in the hall, and I would love to see them all published. I see them every year and never know what happens to them. Publish your abstracts. This is key to getting your wonderful work out. Ask your study teams, your CF teams, how to get involved in research. Stay engaged, and then apply for grants. There are grants available through the Academy of Nutrition and Dietetics that you can apply for and get. And I think also that research dietetic practice group. Mentorship is key. Find yourself mentors and collaborators. I've had some wonderful registered dietitian mentors. Some of you might remember Nancy Wooldridge, who was super active in our CF community, Betty Darnell, Susanna King, and then physician partners and mentors. 3 of you at least are in the room today, that just wonderful mentors and partners, because we do need our clinic partners. Okay, I'm right on time. Summary. Registered dietitians have unique and extensive training and qualifications in diet and nutrition. You are critical for the scientific workforce, for the success of clinical nutrition studies, and the vision of the NIH Precision Medicine Initiative. And RDs will continue to be critical in ensuring the success of CF clinical research and the overall health of the CF population. And so with that, I will end.
Thank you so much. That was wonderful. To get us started with questions, I do have one. A lot of RDs are involved in their QI teams at their centers. Could you talk a little bit about how QI is different from research?
Sure. So I acknowledge I don't do QI research. There's some lovely people in the room that do, but it is important research. It is research specific to where you're working, right? It's meant to improve health in your specific clinic and area. I hope I'm getting this right, Juliana. Versus general research, or the non-QI research, is more meant to be able to help improve the generalized things to the overall population, as opposed to your specific work setting. Did I get that right? Hi.
Jessica, I don't know if you see me via Zoom all the time, but good to see you in person. I just wanted to ask, and kind of, I'm asking because I know the answer, but can you tell me how qualitative interviewing has helped with finding out what you need to know about nutrition, and how that's helping you with your decisions on what tools you're going to use and where you're going from there?
Yeah, well, I think you know very well what the answer to that is. It is qualitative interviews are helping to shape what kind of questions we're going to ask in the future. For Strong, with the Eaton study, the whole reason was to be able to, we're getting all of this quantitative information on 300 people, but with Eaton, we wanted to know what their feelings were about nutrition. Do we even need to be intervening with nutrition and diet? I think the answer is yes. But just to get more descriptive information about what kind of research we need to be doing, how we're going to do it, what do patients want to do, what will they do, what they don't want to fill out a million questionnaires, it sounds like. This is all information that's important and you get from qualitative interviews.
So yes, exploring attitudes towards nutrition, be on the lookout next year. But want to say from the forefront that they're really appreciative of doing these kind of studies. They want to know more, and they're glad that you're learning more too.
Thank you.
Thanks.
Catherine Cutney from Case Western. First, just a comment to echo what you're saying, that dietitians are a very important part of doing research in CF, and shout out to Terry for answering lots of silly questions of mine over the years. My question is about sarcopenia and strong CF. How are you going to measure that?
Yeah, we are getting several measurements. So we're doing hand grip strength. We're getting multiple measures of body composition, including our clinical gold standard DEXA. We're doing questionnaires for frailty. So there's a lot. We had sarcopenia in mind for the strong CF study.
Cool, thanks.
Thank you.
To add quickly to that, what are some of the biomarkers or the plasma and serum biomarkers?
Well, we're getting
the top one.
Well, we're saving plasma. The goal was to save plasma for metabolomics. That's the one that I'm mostly is my favorite one.
Yeah. Thank you.
Great talk, Dr. Alvarez, and you did a beautiful job answering the QI question. I also wanted to highlight the interplay between QI and research. We can often use our QI skills to implement new guidelines or to implement new research to clinical practice. And then through that process, closing the cycle, we can also generate new research questions through QI. So these two things are really connected in that way. My question for you, Jessica, is for the RDs in the room who are maybe interested in getting involved in research for the first time, but are struggling to know how to do that. What would your best advice be?
I think I would start with asking number one, how you can get involved with research that's already going on. I understand you guys have really, really busy clinic schedules, and sometimes it's hard. So it's got to be sort of a passion project sometimes, until your team maybe realizes, wow, she's got some chops at writing, things such as that. So I think just, to me, the first step is like asking how you can be involved. How can I help? Thank you.
And I would add to that really quickly as well, is just talk with your research team about getting city trained, and then also ask about how you can get on to a study doing on the delegation log, doing very small tasks with that. So, but you have to be city trained first.
Thanks so much for a great talk. We've actually had some of these conversations back home, but are any of the endpoints, measurement tools that are typically used in nutrition research sort of things we should be thinking about now to bring into clinic, whether it's, we send people for DEXA, should we be getting more than their bone density or anything else?
Yeah, these are all questions that Strong's going to answer, Sarah Jane. This is what we're hoping. With Strong, we are hoping to be able to get at clinically useful tools. We acknowledge you can't get a DEXA scan every 3 months. So if we find that waist circumference and MUACs, are useful, then that's something we might be able to do, or impedance analysis. We're doing sub-studies on ultrasound of the thigh and biceps that even I've been trained to do, which I'm not a radiologist. So yeah, we're working on that. Thank you.
We have some questions from the app. Are strong CF sites all chosen or closed?
What's that?
Are the strong CF sites all chosen? Is it
Oh,
closed?
huh.
What's the status?
We can talk. We have investigator meetings every other week, and sometimes if a site is really nice to us and we need help, we actually do need help in recruiting. One of our goals, so Melissa Putman mentioned yesterday, we met our halfway point for recruiting. One thing that we want to recruit more of is people with low lung function, and we're having a really hard time recruiting people with low lung function who aren't critically sick. so that's something that we're on the lookout for. And if there's a site that has a large population of low lung function folks, you can reach out to the Strong CF.
Jessica, I want to add to that, please. Also, you can refer people to sites that are participating in those studies. And there's something called the Clinical Research Referral Support Program, the CRISP. And if you help to pre-screen and somebody does a screening and then ultimately gets enrolled, your center grant will actually get money paid to your center grant for referring a participant. So that's another really good way to get involved and to find out. So, and it's also good for your center grant.
Thank you. I love this information.
Yes, and you can always find information about that too on the Clinical Trial Hub. It's a new program, so talk with your lead RC.
Thank you.
Yep.
Kind of related, if your center is unable to become involved in Strong CF, would you recommend doing something similar on a smaller scale in your single center patient population?
Yeah, I mean, I think I've seen over the years lots of studies, lots of single center studies as abstracts that need to get published. Doing that, I've seen just even downstairs, and I think right now, people trying to use BIA, waist circumferences, measuring tape. So I have seen them, and I think that's something doable. You have to go through the proper mechanisms, go through an IRB, but it's definitely doable and should be done.
And then last one from the app, how do you add research to your time without having protected research time?
Yeah, that's kind of what I was saying earlier. You don't, many of you don't have the protective time, so it's sort of got to be this pet passion project for you. You have to really want it, and hopefully, you show productivity, and maybe that's something that you could work to build into your protected time after you've shown that, yes, I've got the chops to do it.
Right.
But it's got to be, it's a passion project, I think, for some.
I would also say you could do a QI project on enrollment into sites or partnering with your research team. And then again, going to the regional cooperative meetings, which is thought of sort of as a research thing, but the co-ops really want the clinical teams to be there as well, because we're really trying to partner with the clinical teams to get to our ultimate goal of finding a cure for CF, and we can't do it if we're not doing it together. So I would say that as well.
You are a wealth of information, Alex.
Thank you so much.
Thank you, guys.
Yes, thank you. Thank you, everyone.